I'm Vijay Kunadian, Professor of Interventional Cardiology based at Newcastle University and Newcastle Hospitals, United Kingdom. Older people are traditionally excluded from clinical research. Particularly 50% of heart attacks happen in people that are aged 70 years of age and over. So if you look at the randomized clinical trial evidence that we have at the moment, there's only 6 small-sized trials with an overall sample size of 1,480 participants guiding the treatment, whether it should be conservative treatment with medications alone or intervention in patients, mostly non-ST elevation myocardial infarction in those that are older is available at the moment. So, and the different studies give different results, so limiting the generalizability of the findings to all the population, all the older adults presenting with NSTEMI. So that's why, in order to make definitive impact on patient care as well as on the guidelines, we need larger studies, and that's what SENIOR-RITA is about. So older people, they're not each one are the same. They're very heterogeneous. There are conditions like frailty, cognitive impairment, multiple long-term conditions determine their outcomes, immediate and long-term. So for that we need to standardize the care for these patients. And when we look at the UK MyNAB database, for example, see how older patients are managed, and this was when we're designing the SENIOR-RITA study, the treatment, basic treatment with medications as well as invasive procedures were much lower as people got older, and only about 18% of people or less received invasive angiography when they were aged 85 years of age and over. Now, as you know, I work in Newcastle, in one of the busiest heart attack centers in the country, and it's case after case we are dealing with patients coming in with heart attack, and you're thinking we must be treating everybody that comes in with heart attacks in the cath lab by doing angiography procedure. But actually, for older people, we were only treating the tip of the iceberg, and many people did not come to see a specialist, or they didn't come to the cath labs. And that's the reason behind it might be because people thinking futility, there's no benefit in treating an older patients with the currently available standard of care treatment, or because of fear of complications such as procedural complications, bleeding, etc. So it's more of a perception than the reality. And of course, with the lack of clinical trials evidence, there is not a definitive understanding of, do older people have more complications? Do they bleed a lot more? Is not currently available, and that's something we have evaluated in SENIOR-RITA. Yeah, so in SENIOR-RITA trial, what we did was we looked at patients who are 75 years of age and over. Our oldest patient that we've included in the study is 103 years of age. So we randomized them, all of them, regardless of their cognitive impairment, regardless of their frailty status. It's pretty much an all-inclusive older adult population. We randomized them into optimal medical therapy with the latest guideline recommended treatments that we have. And the second group of patients who are randomized to invasive care, which involves angiography with a view to PCI or coronary artery bypass surgery. So we let the randomization process determine the treatment strategy in our study, and we included pretty much everybody. So the key findings, when we designed the study, there were, as I mentioned, at the time there was only one study for us to base our power calculations on. So we assumed our event rate based on some of the observational studies. So we wanted to recruit around 1,600 participants. In the end, we ended up recruiting 1,518 participants, overcoming a lot of challenges, including the pandemic. So at the time, we thought with interventional procedures, we can actually reduce the cardiovascular mortality in these patients. Also, by treating upfront, their heart attacks with invasive procedure will also lead to reduction in recurrent myocardial infarction. So our primary endpoint was a composite of cardiovascular death or non-fatal myocardial infarction. One of the unique things about SENIOR-RITA also is that most of the studies we have follow-up only for 1 year, whereas in SENIOR-RITA we have a follow-up up to a median of 4 years. So So with a median of 4 years, comparing invasive strategy and conservative strategy, there was no significant difference in the composite of cardiovascular mortality or non-fatal myocardial infarction. However, when we looked at the components of the primary outcomes, which is cardiovascular mortality or non-fatal MI, there was no difference in the cardiovascular mortality between the two groups. Whereas there was a 25% relative risk reduction in the occurrence of non-fatal myocardial infarction over a median of 4.1 years. In addition, in the invasive arm, we also showed that repeat revascularization procedure was also significantly reduced when compared to conservative treatment alone. So we were discussing why people don't do angiography in older people because of fear of complications, and that's something that we looked at in great detail in SENIOR-RITA, and we showed that the procedural complication overall was less than 1%, which is actually comparable to younger populations. So that's one of the key findings, that it is safe with the current technology that we have in interventional cardiology. We can do, despite the age and the complexity of the disease that these people have, the procedural complication is so low and the procedure as such is very safe. And as I mentioned, the key element is we had over 45% of patients were female. As you know, female patients are grossly underrepresented in clinical research. So we broke that barrier down and we had 45% of patients were female. More than 60-70% had frailty. Either they were pre-frail or severely frail. More than 60% of patients had cognitive impairment. And the Charlson comorbidity index median was around 5, meaning every patient had one or the other multiple long-term conditions. So it's a very enriched study. Overall, bottom line, we did not demonstrate a reduction in the primary outcome, but we did demonstrate reduction in myocardial infarction and reduction in the repeat revascularization procedures. Yes, absolutely. So it's going to, so far we have not had a robust evidence. It helps the clinicians as well as the patients to take an informed decision whether or not a patient should undergo an invasive angiography and revascularization in the context of end-stem. So we can tell the patients, you've come in with a heart attack, by doing the procedure, we're not going to save you from dying due to heart problems, but we can certainly prevent you from having further heart attacks and also prevent you from coming back to the hospital needing repeat procedures. Yeah, so we must not exclude older people from research because we are living in an era of people living longer. And so every clinical trial, we must ensure that we are inclusive of older adults so we can generate more evidence on the best care of not only younger patients with heart attacks, but also older adults. And more importantly, we should also be inclusive of patients with multiple long-term conditions. And it's very challenging. It's one of the toughest things that I've done so far because we were going into an area which has not been done before. You know, we're going into an area of underserved population, underrepresented population. But SENIOR-RITA shows that it is possible to deliver studies, including, for me, they are very precious. They are, of course, vulnerable because of all of the multiple conditions. So hopefully this will enable other researchers. Fine, in SENIOR-RITA, they managed to recruit these patients with so many comorbidities and other conditions, so we can also do that. So that I would like future studies being inclusive because we've already paved the way and demonstrated the feasibility of doing such study.